welcome back to another case-based session. So we're going to go through a couple of these. Going forward, when we do these, we're going to continue to run through it, have you read the blurb, the dispatch, go through the questions, answer them, and then we'll do a recap and kind of go through the things to think about the migration of it. So here you go. All right, so let's recap this one. And we'll kind of slow roll it here. So I'm going to put it in pause. So you dispatched the home of a 7-year-old who came running to his parents saying, hey, the brother said, Billy can't breathe. Okay, so let's think about what are some of the things that pop in your head when you hear Billy can't breathe? So asthma attack, foreign body airway obstruction. Maybe Billy was running so hard that he has exercise-induced asthma. I know one of the things I think about, and I'd learned this a long while ago, NASA had found that as in 40s, if a person's complaining of shortness of breath, can't catch their breath, you should have a high suspicion index for concern for a perfusion issue, meaning something is affecting either the pump, the tubes, or the volume, and the delivery of blood flow to the lungs to onboard oxygen and offload CO2. So anytime you hear somebody, I can't catch my breath, I'm short of breath, other things that pop really high in my head are heart attack, aortic insufficiency, pulmonary embolism, especially things that happen acutely, things that happen quick, need to be fixed quick. So if the brother's running over saying, oh crap, dad, mom, Billy can't breathe, he's not running over because Billy has developed an increased shortness of breath over the last 2 to 3 days. This is an acute instance. This should be of great concern to you, especially a young child. So as we migrate over, we turn on our monitor and let's take just a basic look here and we'll go to get the pressure too. So let's go before. So here we go. So we have tachycardia, so 108, maybe some changes. It's looking real quick at that ECG. You don't have a good PR interval. The P goes right into the QRS. Come down the end tidal, D to E, straight down, back to 0, B to C, C to D. Respiratory rate's 18, not very high. End tidal's a little low though. So the respiratory rate's between the normal rate and the end tidal's slow. So a couple things I want you to think about here. Billy can't breathe. Billy's not tachypnic. Great pulse ox, right? So Billy's getting good oxygen exchange, unless Billy was, working on a generator in a closed garage and he actually has CO poisoning or CO toxicity. And that's a false pulse ox because it's actually looking at carboxyhemoglobin and not oxyhemoglobin. Temperature is a little low, but temperature on our monitors and uncontrolled environments are only as good as they're good as. And so as we're monitoring Billy, what does he do? He goes into this wide complex tachycardia, and it's regular, monomorphic, same squiggle morphology. Goes across, and then he does what? So he's going across, and tidal goes down a little bit. Look at that. So you can see here, he has that drop in perfusion. So this is not an adequately perfusing dysrhythmia. And then he does what? Yeah, he coughs. So you'll see this too in the cath lab. When somebody starts to develop a tachydysrhythmia, you'll see the cath docs ask them, hey, take a cough. What that does is it changes that thoracic pressure, and it helps in a lot of instances with coronary blood flow and also breaking of dysrhythmias. So little Billy gets that kind of fluttering in his chest, like he's going over the roller coaster, catches that cough and breaks it. Pressure's decent, and tidal comes back up. We crank out our 12 lead here, and what do we see? So good axis. So down, up, up. So it's not a right axis, absolute right axis, not ventricular in nature. Because when we're looking at this, it does look like it's a little wide on our QRS. So it looks like it's encroaching on the 0.12. But one thing to really note here in this instance is that PR interval is not there. So what can cause that, right? So if somebody doesn't have that SA node fire, the atrial ripple, which is all the P wave is the atria depolarizing right to left. That's the P wave. The P wave is not the SA node firing. The SA node sends a signal and creates the ripple of the depolarization of the atria. And then you should have that pause, that PR segment, while the signal's going through the AV node down to the ventricles to get that asynchronous kick. But in this instance, there's that slur. There's that little drawl here. And what is that? Well, that's like a bypass. So what happens, or what's potentially wrong with little Billy, is he has an undiagnosed aberrancy, like a WPW. So what happens is you have your SA node, your AV node, and then you have a beltway that goes around the AV node down to the ventricles. And it can, if the SA node fires, it can cause a reentrant tachycardia, causing them to spin up, or it can trigger ventricles to over depolarize. So it can be a couple things. It could be just a fast aberrant SVT, because he already has a widened QRS, because he has that 495 that doesn't slow down to keep the narrowness. So it's a blending of the signal that goes around and the signal that still comes through the AV node. Or it could be that bypass, that 495. I'm in the DC metro area, so all of our bypasses are 495 that go around DC. That 495 triggered the ventricles to fire off. But for whatever reason, he was able to break it on his own by augmenting his thoracic pressure by coughing. Not an uncommon thing to see in people that have aberrant SVTs. You'll also see them try and self-bagel down. You'll try and see them get calm, cool, collected, take short little bursts of a cough. In this instance, young individual, remember, you can't be sick until you're 50, right? So it's these instances that you run them where they had the history of lightheadedness and passing out, and it was never investigated by the parent. It's your assessment, your findings, and what you pass along to the hospital that could be the difference between little Billy getting an ablation early and not having to deal with this for the rest of his life, or just getting it put off. You missed it. You didn't call the shot, and he goes and has this episode occur a couple more times. One of the worst things that can happen is this episode occurs while he's swimming in a pool or riding his bike and becomes lethargic and goes into traffic. So be very cognizant of the net benefit we bring to the table and our findings, especially if this stuff happens in front of us. So which of the followings should be high on your differential list? Well, he doesn't have a flow issue. based on his first breath at birth. So if he was a TET baby, he would not be 7 years old and they wouldn't know. He would have the blue spells that he's clearly not had. Could it be a pneumothoraces? Could, right? You listen to lung sounds, he has good bilateral lung sounds. If it was just a pneumothorax, because one lung is collapsing, what would happen with his end tidals actually go up because his ability to ventilate would go down. So his end tidals low, looking at probably a perfusion issue in this instance, which we saw by that dysrhythmic pattern. Coronary dysplasia, yeah, I just made that one up. And then cardiac conduction condition. Yeah, I think we've kind of discerned that that's the issue with little Billy in this instance. So let's go to the next one. Oh, sorry. What interventions and tests do you want to do? Definitely want to get a line, right? Definitely wouldn't hurt to put the pads on in case he tries to throw that Y complex tachycardia at you again and maybe goes unconscious or develops a non-palpable pulse. You want to be primed and ready for that. So start the line, check the sugar, check the temp, and take him to the appropriate facility, not the standalone ER. This is a kid that needs to go to a place that has pediatric capability, ideally pediatric cardiac capability. So here's your next one. All right, let's recap this one. So we're dispatched to urgent care, 65-year young female, just started a new BP medication. Which one is it? Last week, and has felt weak for the past 3 days. So something that took a little bit of onset, right? Maybe sick and started new medication and also developed an infection, pulmonary embolism, hormone issue, endocrine issue, thyroid issue, right? State she's weak and achy all over. It's never happened before. All right, so something new times 3 days is causing her to become generalized weakness and achy. Hook her up to our magic squiggle box and let's see what we get. So let's start top to bottom. Heart rate, crazy. Heart rate's pretty good, right? In fact, I would argue that 82, it's kind of getting on the upper end of just somebody chilling there, achy and weak. So something to think about. The reason I say that is we get very complacent when we say, oh, well, normal sinus rhythm is between 60 and 100. Yeah, but if you run somebody that's beating 99.9 beats a minute while they're just chilling, that's not normal. Their body shouldn't be running a small marathon while relaxing. So let's keep that in the back of our head because that's kind of on the upper end of, or encroaching on the fast end of normal. SAT's great, good pleth, low amplitude though, so perfusion to that probe is probably reduced. D to E straight down, back to 0. D to E, or sorry, B to C, C to D, so we're good there. How about this? Is the respiratory rate high, low, normal? Normal. And tidal low in this instance. Pressure good. Maps above 65, we're good. Coming back up here to the ECG, look at some of these waves. Are any of them jumping out at you? Anything in your head pop out? So the ECG pops up for us. We've got a good access. P wave for every QRS. QRS is very narrow. What we can see here almost looks like ladling, right? So we start to think about, well, is the medication she's on digitalis? We look at these QTs here. Do we have a lot of amplitude here in the potassium repolarization phase? And it's long. It's not quite long QT, but they're long. So what if her blood pressure medicine was a diuretic, and it's not a sparing diuretic, like an electrolyte sparing diuretic? What can that lead us to worry about in terms of her excreting or urinating out too much of her electrolytes? So in this instance, we look at the repolarization phase, which we start to think about as potassium. We have a low amplitude T wave, and we have a long repol. So this would be a person where we should be concerned about having a potassium deficiency from or being hypocalcemic or kalemic, because the person's excreting too much of their potassium out. So primary impression could be a bunch of things, right? Could be thyroid issue, could be endocrine issue, could be potentially could be an infection. Don't know the temperature on her, but it's a 3-day onset. But she did start a new medication. We should also ask her things like, have you started a new diet? Have you gained weight? Have you lost weight recently? One thing we always forget when we ask about history, meds, allergies is, have you had any recent changes in weight, both in the add or subtract? If you started a medication and you were 62 pounds bigger and you lost 62 pounds, that medication could be chemotoxic to you. Vice versa. If you started a medication and you gained 62 pounds, the medication might not be effective for you. So those are the things you need to think about when you're doing your assessment. And like we said, hey, the changes we see are on that potassium side of the ECG. So let's go to our next one. All right, so let's recap this one. So where you get dispatched to the home of 76-year young male complaining of aching in his legs and arms. Says it started yesterday after he was playing golf with his friends. So what time of year is it? Is he sweating? Not rehydrating enough? I'm sure, as most people golfing, he was not consuming copious amounts of water. It got worse this morning on his neighborhood walk. So increased exertion, re-excitation, or utilization of the muscle groups caused it to worsen. Okay, so we hook them up to our monitor. What do we see? And that's not VFib, right? That's either our coworker put the electrodes and forgot to prep the skin, or that's fasciculations or muscle artifact. So we can see our regular QRSs here falling, but we have all that artifact up there. So things that should jump out in your head when you have that much artifact are fasciculations, twitching. The person amped up? Is the person hyponatremic? Is their serum sodium less than 136 and they start to twitchy? There, as you all know, the Charlie horse, you get that one random muscle spasm that twitches. It's either low calcium, low sodium causing that. We go over to his pressures. MAP is great, right? The numbers look maybe a little low, but he's got a good mean arterial pressure. Come down to end tidal, D to E, straight down back to 0, B to C, C to D. So his waveform looks good, but his respiratory rate's high and his end tidal's low. Okay, so we'll come back to that. Pulse ox, got a great pulse ox pleth with a good dual notch, but his pulse ox is low. Okay, that's weird. He's talking to you, feels achy and weak. Older gentleman by age, young by coolness, of course, right? So let's go on, snag that 12 lead. What do we get here? So going on, axis is an absolute right. Deep S wave here, biphased QRS. Deep Q wave here with a flip T. Come over, it almost looks like he has a right bundle branch pattern, yeah. Okay. Okay. So do we have any concordant ST segment elevation, ST depression, any of those in 2 or more contiguous leads? Because if it is a right bundle, that would be the same criteria stemming, which would not be the same for left bundle. Left bundle would use the modified Scarbosa. So really the only thing jumping out here is the biphase QRS, which looks like he has a slight potentially delay. Don't know if it's normal baseline right bundle branch block for him. But we do have that deep S, deep Q, and flip T. So that is indicative of right ventricular strain pattern, meaning either the right ventricle is damaged from right-sided heart failure, cor pulmonale, or there's something backed up into where the right ventricle feeds, which we all know as the lungs, and it's causing back pressure on the right ventricle, and that ventricle is starting to swell and stretch. Most commonly, pulmonary embolism in the acute phase. You can have stenosis cause that over time. You can have valvular issues cause that, pulmonic valve issue cause that. But in this instance, the two most indicative would be that right-sided heart failure or pulmonary embolism. And if we go back to our pattern, outside walking exertional, and as a reminder, PEs, so just in the back of your head, I know I was taught PEs, the person has a PE, they're essentially going to die, right? Not all PEs are the same. Many of them are different sizes. Some of them can be very small, still impacting oxygen onboarding and CO2 offloading. So it's still impacting perfusion, but that doesn't mean the person has a big saddle branch clot and that they're going to crash on you. So just be cognizant of that. And if this is a PE, what might that young gentleman be on that inhibits his heart rate from going very high? Sure, beta blocker, right? So that's why we have to ask, hey, what could be the issue? So we see asthma attack. We didn't have that loss of C phase in our end tidal, so we don't have bronchoconstriction. Could it be anaphylaxis? Could be. It's not acute anaphylaxis in that it came on all of a sudden with contact, inhalation, ingestion of something. So maybe he has a new detergent and he's reacting to it. And when he goes out and sweats, opens up his pores, it introduces it into a system and it triggers it. Nothing says it can't be anaphylaxis. I wouldn't expect anaphylaxis to take his pulse ox down to 90 though. Could it be a pulmonary embolism? Most definitely. Could it be a coronary artery vasospasm? Coronary artery vasospasm, really what they're trying to get you with that one is do you have signs of coronary artery occlusion? Because no different than your right calf muscle, your coronary arteries can have a Charlie horse and vasospasm, Prinz-Metal's angina, unstable angina, vasospastic angina. You can have the artery actually spasm, stops blood flow, causes the ST changes, very similar to a heart attack. We didn't see those. So we saw the strain pattern, we saw a person hypoxia, we saw generalized weakness, probably on a beta blocker, which inhibits his ability to tack up. I would say it's probably C, a smaller pulmonary emboli. Does the 12 lead look at the full circumference of the heart? No, it does not, right? It looks at the front wedge and then the right undercarriage. It does not look at the back. It does not look at the right wall. We have to add to that to make it a 15 lead. And then, is this an occlusive coronary issue? I don't think this is an occlusive coronary issue. My worry that this would be a pulmonary embolism that has the potential to get worse and or migrate. And then subsequently, where did it come from? Did it come from a DVT from sitting all winter and finally going out golfing with his friends and he migrated and there's a bigger clot down there that could be shooting micro clots throughout? The other concern is if you did have a migratory emboli or clot, is it other places? Does he have ischemic bowel? Has he had, issues cramping in his intestines? Does he have limb ischemia? Does he have other areas where other clots have gone and migrated that are also becoming problematic? So I'll be very concerned with that. All right, let's do a last one here. All right, so let's recap it. So dispatch to the home, 77-year young female, weak and short of breath. All of the sudden, during a bridge game, pretty intense bridge game, I'm sure, has a history of heart problems, speaking in one-word sentences. Sudden onset, one-word sentences. This is not going to be a good day. Good day. Let's see. Dial over. All right. So what do we got? So heart rate 89. Okay. So looking at, looks like some ST depression. Let's look at the pressure. Oof. Map of 126 and that diastolic. Everybody always jumps to the systolic. I get worried about the diastolic. When you have high diastolic, your resting pressure is high, your capillaries don't get a chance to relax. They don't get a chance to relax. They start to stretch and the cellular adhesions start to pull. That's when you get that capillary leaking. Now we go over, we look at a D to E straight down, kind of back to 0. Yes. B to C, C to D. Rounded. When you start to see rounded wave like that, you need to be worried about a pulmonary edema, so fluid in the lungs, whether it's from pool water, or plasma from the high diastolic or pulmonary pressure. That's a person who looks like they have pulmonary edema in their lungs. And their respiratory rate's high and tidal is low. So they're breathing fast, blowing down their end tidal. Remember, CO2 moves through liquid very well. Oxygen does not. So having that liquid kind of trigger here says, hey, that's migrating out because we're breathing fast. Oh, wait, they're not able to bring oxygen through that liquid. So that would make sense, right? So they're not able to push that through. Remember, oxygen through a liquid needs pressure. All right, so let's see what we got next. Audible sounds were crackles. So we heard that. So it's definitely thinking us to the fluid in the lungs. We go back, let's crank off that 12 lead. Anything jumping out at us? Go down, up, up. So we have discordant. So come over here. We have discordant, discordant, discordant. All right. Looks like, can't tell if that's why. This looks like ST depression here, right? This looks like it. My concern on this one might be a reciprocal change for elevation, but I don't see anything anywhere else that says, hey, yeah, that's elevation. So I'm going to err based on all this other discordant change that it's probably a left bundle branch block that she's experiencing. Might be her baseline, might not. We don't know her. So we come back. Nothing else was jumping STEMI. Media action. So let's say she has that history of congestive heart failure. You know, her left ventricle has about that much chamber size where her right ventricle has that much chamber size. So she has a backup. And it's usually acute stressed events that do this, getting cut off, finding out a friend passed away, winning a bridge, losing a bridge, finding your daily habitus was broken, you know, like, hey, Terry had to cancel. We can't play bunco tonight. So it's that stress or startling in their sleep that they can't catch their breath that causes that sympathetic surge, peripheral vasoconstriction, shunts blood to the core, surges to the right. Right is giving a ton, left can't take a ton, backup happens in the lungs. Stress state, clamping down, resting pressure goes up, diastolic goes up, which means the capillary beds are doing this, plasma's leaking out, fluids going in the lungs, they're breathing fast, causing that bubbling. So the issue really is the fact that they had a stressed event. Now they're stressed because they can't breathe. We need to help them with that. We need to help them with that oxygen exchange. So how do we do that? So CPAP is our best friend, right? We make our alveoli bigger. We don't push the fluid out of the alveoli. We don't have that type of pressure with 5, 7, 10 centimeters of PEEP. What we do is we make our alveoli balloon bigger, increase the exchange area, the oxygen exchange area, get better gas exchange. So CPAP's easy, right? Throw CPAP on. She definitely has a pressure that'll tolerate that. Put CPAP on, start at 5 centimeters of water. Where I work, we give 0.8 milligrams of nitroglycerin for a person that's this severe. She can tolerate this. What nitro is going to do is it's dilating that vena cava really big so that you decrease that preload. So that right ventricle stops being overrun with tons of volume that has been shunted to the core so that it stops trying to ram that over to the left ventricle, which can't take it. So what we're doing is we're increasing oxygen exchange capacity by doing PEEP, dilating the preload, so stopping that overrunning volume on the heart by giving high dose nitrates. And then really the last thing we need to do is that 12 lead we did just to make sure that it wasn't an MI that triggered this. So if we can get them early, get the PEEP to help the oxygen exchange capacity, get them out of that stress phase because we're going to start to climb their O2 level back up, and then open up their preload. So we stop overrunning the right side of the heart, which is trying to power load the left side, which can't tolerate it. And then rule out that it is acute MI that caused this. Not super hard. She doesn't need to be paced. Her heart rate's fine. She doesn't need to be crite. She's talking one-word sentences, and her wave doesn't discern that she's not exchanging through there. She's talking to you, so it's not like her airway's closing. So yeah, sounds like a acute pulmonary edemic event secondary to a bridge game. So what are other concerns for her, right? What if you start at 5 centimeters of water, 0.8 of nitroglycerin, and she doesn't get better? What can we do with that PEEP? Go up and more, go up and more, right? That's some of the great things now with, if you look at the Pulmodine trio, you can get 3 settings of PEEP, 5, 7.5, and 10. They also make one up to 15. And then if you go down to the bottom, it starts at 30% FiO2, but you can change it to 60 and 90. When you see somebody with a low SpO2, you should think of how can I help get their alveoli bigger? So if you dance them up to 10 centimeters of water on that PEEP, and their pulse ox is just starting to steadily climb, you can go down on that trio and turn it up to 60% FiO2 to increase the saturation of the oxygen that's being delivered. So that's one of the cool things with some of the more advanced CPAP circuits, that disposable ones specifically that are coming out, is like with that trio, you get 3 PEEP settings, 3 FiO2 settings. So if you've got your PEEP rolling and the max, now you can start to increase the saturation of oxygen in that delivery of what you're doing. And the benefit is, although you're nitrogen washing them, you're also delivering that oxygen with pressure. So it's not like you're causing atelectasis, because you're literally preventing full exhalation. And I want you to think about this. If I put you on CPAP and I inhibit your end expiratory ventilation, so I put positive end expiratory pressure on you, so I put positive pressure on your trying to exhale, are you able to fully exhale? You are not able to fully exhale. So what is that going to do to your end tidal value? By nature, if I put anybody on CPAP, 5 centimeters of water, put it on their face, get a good seal, and they start breathing. Let's say we don't even add any oxygen to it. I just put you on CPAP. What is that going to do to your end tidal? By inhibiting full exhalation, I'm going to make your end tidal get higher. So it's one thing to remember when you put somebody on CPAP, it's a manifestation of what you're doing. When I put you on CPAP, your end tidal is going to start to climb because I'm inhibiting full exhalation. It's one thing I like to remind people, because a lot of times people will put somebody on CPAP and think they're going into failure because their end tidal is starting to climb. That's not the case at all. You literally are just changing the mechanics of the breathing process, and you're supporting inhalation by delivering oxygen, and you're inhibiting full exhalation. So you have the flow restriction by that little flutter valve at the top that's allowing some of that CO2 to reside after the fact. So when you give somebody CPAP and their end tidal starts to climb, they're not crashing. You don't need to lay them back, put pads on, and worry about them coding. It's the device or the therapy that you've decided to apply going into effect. So